Hi, everybody. Welcome to the 7th Annual Food is Medicine Symposium. My name is Robert Greenwald. I'm a professor of law here at Harvard Law School.
Feedback.
Yeah, a lot of feedback. And the faculty director of the Center for Health Law and Policy Innovation here at the law school, which houses the law school's health and food law clinics. We're really excited to be hosting this annual meeting and to mark another incredible year of progress in the food as medicine movement. As many of you have come to this event before know, when we talk about the term food as medicine, we're talking about efforts to integrate food and nutrition services into our healthcare delivery and financing systems, with the goal of better individual and community health outcomes and of reducing overall healthcare costs. At the Center for Health Law and Policy Innovation, we're committed to promoting reforms to both the health and food systems, making them more effective, equitable, and just. And food as medicine is our sweet spot, if you will, because we have health and food law and policy teams that work together on this issue. We're delighted, as always, to be hosting this event with our collaborative partners, Community Servings, an organization which is recognized here in Massachusetts and nationally as a food as medicine innovator. Without Community Servings' mission and commitment, led by its CEO, David Waters, the food as medicine movement would not be where it is today. And that brings me to the question that this symposium is all about and is trying to answer. Where, in fact, is the food as medicine movement today? In the next hour and a half, we'll hopefully provide some answers to that question. This year, focusing particularly on how stakeholders from across the health and food systems here in Massachusetts are successfully working to secure the integration of food into our healthcare system. But first, I want to take a few moments to step back and to celebrate the successes we've had in the past year in the food as medicine movement writ large, highlighting the progress being made on both the federal and the state levels. Starting on federal successes, Medicare will soon greatly increase opportunities to support access to food as medicine. Starting in January 2020, a change in federal law will allow all Medicare Advantage plans across the country to cover a wide range of food as medicine interventions, including medically tailored meals, produce, and transportation to access food. Under the new special supplemental benefits for the chronically ill program, Medicare Advantage plans will now be able to provide food as medicine interventions to all patients who have one or more serious and complex chronic health condition and a high risk of hospitalization or other adverse outcomes. This is exactly the population that many of our food as medicine programs are designed to provide services to. Also, starting in 2020, all Medicare Advantage plans will have the opportunity to participate in a value-based insurance design program. This program allows for the provision of food as medicine services to beneficiaries based on chronic illness, socioeconomic status, or both. And what's unique about this program is it recognizes that food as medicine interventions have a role to play in improving health outcomes and reducing healthcare costs across socioeconomic status. So as with other interventions in the Medicare program, this service is available to everyone where it's medically necessary, to all Medicare Advantage beneficiaries whose plans are participating in the program regardless of cost. In addition, on the federal level, food as medicine interventions have gained traction in the Farm Bill, with the most recent Farm Bill allowing for the funding of produce prescription programs. This initiative will expand access to a core food as medicine intervention across our country, and it includes a research component that will build the evidence base that is needed to support the broader integration of produce prescriptions into our public and private health insurance systems. On the state level, we are also making great progress. First, we've seen great growth in the reach of food as medicine programs in states across the country. For example, the Food as Medicine Coalition, the National Coalition of Medically Tailored Meal Providers, report that in 2018, they served over 57,000 individuals across 15 states. This includes providing over 1.3 million meals to over 6,500 individuals through health system financing. So it's working, this idea of food as medicine and integrating food and nutrition services into our healthcare system. And the medically tailored meals providers have obtained tens of millions of dollars in contracts, again, healthcare financing, to support the integration of medically tailored meals within a healthcare system. The coalition also continues to work to build the research base that is so critical to expanding the integration of food as medicine into our healthcare systems. We're going to hear about some current research today, but more broadly, Food as Medicine Coalition members are currently involved in at least 8 studies to assess the impact of their services. As to state-specific progress, last year we featured a presentation on the start of California's piloting of the largest food as medicine intervention within a Medicaid program in history. Currently, state food as medicine providers in California are now halfway through this pilot, providing a 12-week medically tailored meal intervention to individuals who were recently hospitalized with congestive heart failure. The pilot includes 7 counties. That's about approximately 50% of all Medicaid beneficiaries within the state of California. And once this is complete, we will have significant new evidence as to the role of medically tailored meals post-hospitalization for people with serious health conditions. I believe there was an article today in the New York Times about this, and the preliminary evidence shows how the provision of medically tailored meals post-hospitalization to folks living with congestive heart failure both improves health outcomes and reduces healthcare costs. Again, that is what food as medicine is about. North Carolina has recently approved a Medicaid waiver to implement a new program that includes food as medicine services. The Healthy Opportunities pilot includes the provision of medically tailored meals and healthy food boxes to beneficiaries who qualify based on health and social risk criteria. And of course, we're making great progress here in Massachusetts. Starting in January 2020, MassHealth will launch a $149 million flexible services program. The program will provide MassHealth accountable care organizations with unprecedented funding to directly address the nutrition and housing needs of some of our most vulnerable Medicaid beneficiaries. Under this new program, accountable care organizations will be able to provide healthy meals, including medically tailored meals, transportation to grocery stores and food access points, nutrition education, and assistance in obtaining cooking supplies. And finally, as to tonight's symposium, we're going to tell you a lot more about the implementation of our first in the nation Massachusetts Food as Medicine State Plan. But drawing on the input and the investments of stakeholders from every region in the state, many of whom I see here today, the state plan is a comprehensive strategy for advancing access to critical food as medicine services here in Massachusetts. You'll be hearing a lot more about the state plan this evening, but briefly, its implementation is being driven by a statewide coalition and 3 task forces that are working to turn the promise of food as medicine to a reality here in Massachusetts. The state plan is helping to shape food as medicine conversations with the legislature and is informing the work of our lead legislative and administrative champions. And it's working. This week, Senator Julian Cyr and Representative Denise Garlick introduced a bill in the Massachusetts legislature that calls for the creation of a pilot program that will evaluate the impact of providing the continuum of food as medicine services to MassHealth enrollees living with chronic health conditions. So clearly, it's all a work in progress, but in so many ways, we have come a long way since a small group of us met 7 years ago at the first Food as Medicine Symposium to really discuss what was then mostly a concept. Over the past 7 years, food as medicine providers have successfully expanded our reach, and we are serving more and more people who desperately need food as medicine. So we hope you'll consider joining the Food as Medicine Massachusetts Coalition and becoming part of this success story. It is still a story to be told, and there is room for everybody to help make, again, the promise of food as medicine a reality. So finally, there are so many people that we should thank that helped to make this and really the food as medicine movement writ large possible. But just to name a few, I want to acknowledge Sarah Downer, Katie Garfield, Kristen Sukis, Emily Leib, Jean Terranova, David Waters, Kurt Hager for their work, particularly in putting this event together. So I hope you enjoyed tonight's symposium, and thank you all for being here. And I'm now going to turn it over to my good friend and colleague, Emily Leib, professor here also at Harvard Law School, to discuss the findings and recommendations of her recent report, which outlines the policy tools needed to successfully include nutrition education in U.S. medical training. Emily Leib.
All right, I just came right from teaching, so just going to put my speaking hat on. Thank you so much. I want to not go through the whole same list, but I think the folks that Robert identified at Community Servings and within the Center for Health Law and Policy Innovation have done an amazing job on this work and putting this event together this year and every year, so thank you. All right. So I direct the Food Law and Policy Clinic, which is a division of the Center for Health Law and Policy Innovation. And as part of my program, we educate law students about the laws that regulate the food system and policy decisions and debates going on in the food system. And then we work on real-world projects within trying to make food healthier, more sustainable, more equitable, better in lots of different ways. So I'd like to give this little story, and I got to do this last week at a congressional briefing, but a few years ago I had a student at Harvard Medical School who was in the back row, Chris Murray, cross-enroll into my course here at the law school. And at the end of the semester, Chris said, "Isn't it strange that I had to come from the medical school over to the law school to learn something about food?" And I said, "Yeah, that's really weird. Is that true?" And he said, "Yeah, I haven't learned anything." So I went home and talked to my father, who's a physician. He's a gastroenterologist. And I said, "Dad, did you learn anything about food? Do you know anything about diet?" And he's like, "No, I don't. Actually, I didn't learn anything about it in medical school, in residency. I haven't learned anything since then. I literally know nothing about diet." So, okay, that seems to not make that much sense. As a result of these discussions that really piqued my interest, the work that we've been doing already on food as medicine, and even realizing that if you want doctors to tell patients better what they should eat, what's a good diet, give them good advice, and then also make critical and vital referrals to nutritionists and dietitians who can help them, then doctors need to understand some basic information about food and nutrition, but also know that it's really important so that they're making those referrals. So basically, we don't know what to eat. In this country, nutrition plays a critical role in wellness and in some of the most common and costly diseases facing this country, and yet our doctors aren't equipped to help us. In terms of the medical education, the average medical school, for example, offers less than 1% of its lecture hours in anything that relates to diet and nutrition, and even those that they do have are very focused on specific nutrients. Like we've heard lots of doctors know that if you don't eat vitamin C, you'll get scurvy, but scurvy isn't the #1 disease facing the United States today, as it turns out. So that's not that helpful, and it's not required that they learn anything beyond that. For residency and fellowship programs, which is after medical school, I'll get into this a little more, but the accrediting body doesn't require any knowledge or competency in nutrition, diet, food. The STEP and board exams that physicians must take throughout medical school and afterwards nutrition is very rarely tested, if at all. And I could go on. So the end result is that 86% of physicians report that they feel unqualified to advise their patients about diet. So, this is a problem. And further, just as one example in a field that we would think is very relevant, 90% of cardiologists recall receiving no or very little instruction in nutrition or diet throughout their education. So, if you want to look at, if you went through all the specialties where you would think that diet would be relevant, you would find similar information. So the report that Professor Greenwald, Robert mentioned, that we just put out is called Doctoring Our Diet, and this was the result of a collaboration between the clinic and a group called the Nutrition Education Working Group, which is a group of concerned public health and medical educators and practitioners, primarily folks here at Harvard at our public health and medical school, but also including some medical students and some folks from elsewhere that have been working together over the past few years to try to understand this problem and figure out what they can do. And what they did was they asked us to come in and kind of map out for them a range of options for the ways that they could change this. We prepared that, we gave that to them. We've actually already been working through some of them, which I'll mention, but the end result was that we published this in this report that came out last month called Doctoring Our Diet. And I want to give within that group a particular call out to Dr. Stephen DeVries and Walter Willett, who are two of the leaders of the group and have been really close partners. The three of us, myself included, had an op-ed out last week in The Hill that talked about this as well. So one of the first things we did, this was a fun project with my students, was we sat in a room for 3 hours and we tried to map out the education of physicians and then look at each level of education, which those are the levels, what are the different policies that could actually move the needle, and then who are the decision makers. So I'm not going to go through this, it's in the report, and you can kind of get a closer look at that. But I am going to tell you about a couple of those really quick. So the first is in terms of accreditation. For medical schools, the body that accredits those is called the Liaison Committee on Medical Education, the LCME, and then the American Council of Graduate Medical Education, the ACGME, does accreditation for residency. So one change could be these are external bodies, but you can submit comments to them. You can ask them to change the standards. We have not yet tried this with the LCME, but we have done this over the past few years with our working group with the ACGME. We wrote comments to them. They have open comment periods on their website. I'm happy to share it, and we can flood them with even more comments. But we wrote comments on their common program requirements that apply across all residency programs. We wrote comments on pediatrics, on surgery, and on family medicine, asking them to include a requirement of competency in something related to food and diet, and we've had no impact. And interestingly, just as an example, for pediatrics, it's about a 40-plus page set of competency standards, but there's no mention of food or diet or nutrition. The only time that those words appear is in terms of the diet of the physicians in training themselves, and it says we should make sure that the physicians in training have good food and a healthy diet. So if it's important for them, you would think it's important for their patients too. So that's one place we can change. Another place would be within the funding for medical school. So I'm not going to go through these options, but I think we explore in a lot more detail what this could look like. You could, for government funding that goes to education, you could condition that on really educating about some amount of diet and nutrition and say you're no longer going to get those dollars. There's a lot of federal funding that goes to medical schools, especially through grants, but also some direct funding. And then more than 40 states give Medicaid dollars to medical, to residency programs at least. You could give grant funding to schools, to outside organizations to test the curricula. There's lots of places that dollars could go if we wanted to prioritize this. Another example I didn't mention before, but continuing medical education. In every single state, the physicians are required to take a certain amount of credits of continuing medical education each year. 37 states currently require that CMEs, certain of them have to be in specific areas, but none of the 50 states require anything in diet or nutrition, and that could be changed. Right now, both New York and DC are considering requiring CMEs in nutrition, and we'll be having one of our students actually test testify in DC next month on the DC bill, which is really cool. And then at the federal level, the federal government could require CMEs of doctors and physicians employed by the federal government in things like the Indian Health Service or the Veterans Health Administration. The exams, I'm not going to go so deep here, but these I mentioned before, the exams very rarely test nutrition and it's not called out, and that could be changed as well. And our working group actually wrote some exam questions for within the board exams that physicians need to take to be board certified and practice in their specialty areas. The Nutrition Education Working Group has been attempting to write questions to be adopted in the internal medicine board exam. So it's slow going, it's question by question, board by board. That's going to take some time, but I think could make a difference. I want to focus for a minute on an area that we've been really interested in, where I think there's potentially the best case to be made, and that is in the funding of graduate medical education, which includes residencies and fellowships. And the reason is that training hospitals that train our residents and fellows rely almost exclusively on federal dollars to support that training. So $15 billion per year of federal funds go to training of residents and fellows. The largest portion of that is from Medicare, $10.3 billion a year. And then also some amount of that comes from Medicaid, because the federal government matches the states that give state Medicaid dollars to training. So interesting, Medicare, excuse me. So $10.3 comes from Medicare, and right now that funding comes without any strings. The only thing that programs need to do to keep getting those dollars is to maintain their accreditation with the ACGME, which, as we discussed, doesn't require any training on diet or nutrition. At the same time, Medicare spending is skyrocketing. So in 2019, spending on Medicare benefits will be about $731 billion. And in the next 10 years, it's expected to exceed $1 trillion. And 5 of the 8 most common conditions that are treated, that are of Medicare patients, are diet-related. So 1/3 of all of Medicare funding goes to pay for diabetes treatment, which is clearly related to diet. So we're spending Medicare dollars to train physicians who then don't know anything about the diseases that Medicare is spending all of this money to treat. It doesn't make any sense. So there's lots of ways to change this. I think for Medicare specifically, it would have to be a statutory change, likely because the language of how that funding is allocated is set in statute, but this is something that we can talk about. And then for states that are giving Medicaid dollars to schools for training, those states could change that at the state level. Again, lots of opportunity, and we go into this in a little more detail in the report. Again, I'm not going to go through all of this, but just to show you, we went through a lot of these options. There's a table at the back of our report that goes through some of these, and we're really hard at work now on some of the next steps. So I mentioned we had a congressional briefing last Friday. We're working really closely with Representative McGovern, who's been in previous years honored at this event. He's a really great champion of these issues and has been really excited. So we're going to be working on definitely for now a congressional resolution, potential legislation, and then some other opportunities that we've identified with him. We are building our coalition if people are really interested specifically in this topic. I think one way to get involved is there's state level work going on specifically on this, and then we'll be also communicating with that group that's working on these issues in Massachusetts and thinking about how we can bring those voices as well to some of the broader conversations. All right, thank you.
So I want to say thank you, and Emily, could you stay there for 1 second? Take a question. I have one question for you while we start, and then folks, you have your cards, or hopefully you have index cards, and you can write them down, and I'll walk through the aisle while Emily's answering questions so I can take a couple more. But Emily, of everything that you've mentioned here, in your view, what's the lowest hanging fruit? Where do we start? Because there was a lot, but I just talked about.
I mean, it's hard. I think I've been really focused on this Medicare piece because it just seems to make so much sense, but I would say it's probably the highest fruit because it's, a really huge thing. That said, I think what we have found through our research on this is that there's been a huge dialogue kind of parallel to this around trying to have more accountability for graduate medical education. So there was a GAO report about it that came out last year. The president's budget has been talking about this. HHS has been talking about it. There's a lot of dialogue about how can we tie the funding for residency training on more outcomes. The outcomes they're talking about are more about getting residents to go into rural areas or healthcare professional shortage areas. So what I think would be really helpful is if those things move forward, trying to bring into that as well some of these quality things like can physicians actually treat and prevent some of the most common illnesses that we're facing.
So one other question that, well, I'm waiting for questions. Hold it up when you get it. One other thing that we've heard is, well, are we trying to make doctors into dietitians? And so have you heard that, and how would you respond to that?
That's a really good question. Yes, a lot of people get really nervous and ask this question. And we've spent a lot of time, I've been thinking about it and talking about it with our working group, and we do work with a lot of dietitians as well. I think what we hear constantly from dietitians is that they have more capacity and would like more referrals and would like to see more patients. So I think it's really vital that the doctors, there's no way that they're going to be able to know everything and stay up to date and spend the time with patients to actually build a healthy diet. But if they don't think that this is important, then they're never going to make those referrals and get people into the care that they need. So I think I'm going to draw on Chris and the other physicians that spoke last week mentioned, they learn a lot about making referrals to other specialty practices, other physicians, like you're in family, in primary care, you make referrals to cardiologists, et cetera, but there's not training on when do you make referrals to dietitians, and I think that's a really vital piece of this.
And then I have one more, an extension of that question, I think, which is that a lot of the care for Medicare and Medicaid population is delivered by nurse practitioners. So have you looked at the requirements for them, and are they included in your planning?
That's an excellent question. I have not, and I think we're starting now that we're having more dialogues about this to think about the range of health professionals and how to make this more part of it. So I think whoever asked that question, I would actually be really curious and would love to talk more. Okay, thank you. Great. All right, thanks.
Okay, so while we're finishing getting set up here, I'll start doing a bit of an introduction. So Robert did an amazing job in his opening remarks, really giving us all a lot to think about how far we've come as a nation on this issue just over the last couple of years. Now it's my job to take us a little bit more local and say, let's step back for a moment and think about how far we've come as a state and just as a group of people in this room over the last couple of years. So now this is our 7th year holding this event. And I have no doubt that some of you in this room have been here every one of those 7 years. And so you can actually think back and say, where were we even 3 or 4 years ago? And how much have we just learned in those couple of years? So think about our state plan initiative that we talked a lot about last year, where we really spent 2 whole years examining the state of food as medicine in Massachusetts. And we did so much work there that really hasn't been done in another state, which is amazing. We conducted GIS mapping. We collected over 200 surveys. We conducted listening sessions across the entire state. And we conducted interviews with the actual people on the ground who use and need these services most. And through all of that work, we have learned so much. So what do we know now? We now know, due to all of that, that we can identify 26 municipalities in the state where rates of food insecurity, chronic illness, and lack of transportation tell us that there is a real critical need for access for food and nutrition services, and especially connecting those services to our healthcare systems. We also know, which is amazing, that there are at least 63 programs in the state of Massachusetts that self-identify as providing a food as medicine service, one of those services in the pyramid that we like to tout so much. And that's fantastic as a baseline. However, we also learned through that process that there is an incredible diversity of what is available within each of those categories. So there's a greater need for standardization, creation of definitions, and really putting into words what we mean when we say these things and making that uniform across the state. And also, we know that healthcare providers across the state believe in the benefits of this work. They believe in the value of screening for food insecurity. But however, we also know that they face a lot of barriers. They feel constricted by lack of time with patients, and they worry that they don't know what resources exist in their community, so they worry that there's an ethical issue with them screening for something that they can't address. And finally, we know that many insurers in our state actually believe that it's beneficial to support food as medicine interventions, but that few organizations who currently provide food as medicine interventions receive funding from insurance. So we know all of that. And we also know that we're in a moment of tremendous change as a state. Starting in January, mass health providers have this new opportunity, as you heard about earlier, to provide flexible services through the Medicaid system where they can actually address nutrition and housing needs for particularly vulnerable patients. And we also know that as part of the ACO process, those numbers that we found in the report around screening are hopefully changing. The mass health providers really should be screening for food insecurity now. So I hope that if we were to redo that survey, that part of the picture would look very different. So we know all of that. We know we're at this great moment. We know what our baseline of organizations are. We know what the big gaps and obstacles are. So what we now have to turn to is the question of where do we go from here? So I'm up here today with a group of individuals that are trying to think through that exact question. So since the launch of our state plan report this past June, these individuals and their colleagues have been hard at work on the Food as Medicine Massachusetts, or FIMA, coalition. That's a coalition of organizations and individuals dedicated to realizing the vision that's outlined in the state plan. And these individuals here today are some of the leaders of the 3 task forces that sit within FIMA. Those task forces are really the active bodies in the coalition that are driving our recommendations and our work around those recommendations. And so those task forces are really focused on 3 priority issues that we identified through the state plan process. And I'm going to let them tell you a lot more about the work of their individual task forces in just a moment. But let me just begin by introducing them as individuals. So first, we have the Community-Based Organization Task Force. That task force is co-led by 2 great community-based groups. So Jean Terranova and Hannah Sobel of Community Servings, and Rachel Cady of the Greater Boston Food Bank. Representing the task force on our panel today is Jean Terranova. Second, we have the Research Task Force. The Research Task Force is led by Rich Sheward and Charlotte Bruce of Children's HealthWatch, an amazing group doing a lot of research and advocacy in the area of social determinants. And representing the task force on our panel today is Charlotte Bruce. And then finally, we have the Provider Nutrition Education and Referral Task Force. This is the group that's tackling that issue that you just heard a lot about from Emily Leib. That task force is led by really 3 powerhouses from our state plan project, Dr. Kumar Siddhartha of Cape Cod Healthcare, Robin Alley of Massachusetts Medical Society, and Dr. Kathryn Brodowski, who's representing the task force on this panel. So first of all, I just want to take a moment and thank you all for your work on FIMA. So thank you. Thanks for having us. Yes. And I'm going to start off with a couple of questions just to get a sense of what your work is focused on, where it's going, and then I'll open it up to the audience for questions. Again, if you have questions, please write them down on those cards and provide them to Sarah Downer, who will be walking around. So first, I want to start by asking all of you, just to lay out for the group, what is the core problem that your task force is trying to respond to? So let's start with Jean.
Sure. So the community-based task force is really trying to come up with definitions of these interventions that will hold across the healthcare system so that there is not confusion about what is a medically tailored meal, what is a medically tailored food package, et cetera, because the healthcare system really needs to have confidence that the intervention that they are prescribing is actually what we say it is. And I think that some of this confusion comes in because we now have this growing body of evidence that demonstrates that these interventions, in particular, there is evidence on medically tailored home delivered meals, as well as diabetic meals that are picked up at a food pantry, for example, that shows that these lower costs improve outcomes, improve patient satisfaction, and if what is being kind of prescribed is diluted, then you're not going to have these impacts, and it really can undermine the work that we're all doing. So we need to have a consensus on what these interventions are. And in addition, when we do all come to clarity around that, we can help expand access to these interventions to consumers who are at risk for or coping with chronic illnesses. We can support through our philanthropic community investments and scaling of these programs. Healthcare payers will be confident in reimbursing for the services. And then we can also help support the system of referrals from consumers in the healthcare setting. So that's really what our goals are. The barriers are really, confusion of what the definitions and standards are, knowledge, education. Those are the things that we're working on the CBO task force.
Great. Then same question to you.
Yeah, thank you so much. So with the Provider Nutrition Education Referral Task Force, if you think about food as medicine, basically, you need to, as a provider, be able to identify folks who have issues, nutritional issues, and then connect them to resources. But one of the core problems is so many providers don't feel empowered to have those conversations. I think as Professor Brodowski just eloquently pointed out, you take medical schools, and Matt, I'm with you, I'm a preventive medicine physician. I had maybe a class in biochemistry on nutrition and very little thereafter. So there's a real lack of nutrition education among a lot of the provider groups. And I want to just take a moment and say, it's not just physicians. When I say provider, we're talking a lot about allied health professionals. So think about, medical schools, but also think about oral health, nurse practitioners, a variety of different folks that really have the opportunity to speak with patients, identify and connect them to resources. But really, again, just taking an example of the medical school curriculum, 71% of 121 medical schools don't even meet 25 hours of nutrition education over their 4-year curriculum. I mean, to me, that's astounding. So if we want to empower providers, we really need to take a moment to understand where they are and figure out how we can help, beef up nutrition education. So our task force this year and thereafter is really taking a look at how can we help providers get more nutrition knowledge to be able to have those conversations to identify and connect. And this year, we're really focusing on core competencies, the language around which we can hopefully adopt out to many different training programs, whether they be medical schools, oral health schools, a variety of disciplines. But we'll kind of segue back to that and talk to you a little bit more about the core competencies. But that's really the problem that we're facing and the challenge that we have set on the table for this year.
Thank you. And then Charlotte?
Yes, well, thank you for having me. And so the Research Task Force, what we're really doing is responding to the fact that data drives implementation. And given this opportunity in Massachusetts and nationally to really implement interventions that focus on social determinants of health and focus on food as medicine interventions, we really want to expand the research that's out there and elevate the research that's out there that that provides evidence that this is a meaningful intervention that can address health outcomes and reduce costs and reduce healthcare utilization. And so our goal as a task force is to identify what's out there and to really fill in the gaps of the food as medicine research. And we are doing this in a few different ways. And again, like the others, I'll go into this in a few minutes, but really focusing on the research capacity.
Great. And then I think all of you have alluded to this to a certain degree, but just to give a sense, what's really the long-term vision or goal for each of your task forces? You know, if we're looking back in 10 years from now, what is it that you want the work of that task force to have accomplished or to help drive from a change in the Massachusetts healthcare and food systems?
So we want to see the rigor of the definitions and the rigor of the services be treated almost like a prescription in a medical care setting. And for that, we need to see community-based organizations be very well supported, have sustainable funding to be able to offer the programs and services throughout the entire continuum, the pyramid that we use, and throughout the entire state of Massachusetts. We want to see screening, referrals to appropriate levels of services, evaluation, and continuous quality improvement in the same way that occurs with a prescription medication for people coping with diet-related illnesses throughout the entire state. That's the long term.
Yeah, so breaking it up into short-term versus long-term, the short-term goal, at least for this year, is to come together as the task force and set out what are the core competencies that we could offer out to training programs as really the stepping stones to incorporate more nutrition education into their programs. We're taking a page really from what was done with DPH and the Mass Medical Society, whereby they really reached out to medical schools with opioid core competencies to address the opioid crisis. Nutrition, very similarly, is a huge problem in our state. There are major differences, different political backings, different kind of levers that we need to think about how to get the core competencies to training programs. But our first idea is to really target training programs and provide them with core competencies that would help. What are the things in the nutrition realm they should be teaching to medical students, nurses, oral health professionals? And also under each of these core competencies, what are the resources available? Because we want to make sure folks have a way, if you're going to say, let's screen for food insecurity, make sure they know what are the screening methods out there. If we're going to refer to community organizations, are there technologies or other resources already available to connect them? So really to provide a list of core competencies that training programs can uptake, and also provide resources under each of those core competencies, so we leave them with really a way to uptake those competencies. The second portion is, we have to think about professionals who are currently in practice. So people who have been out in the field for 10 years, 20 years, how do we reach them? And part of the issue is, what are the gaps in current continuing education? So we're hoping this year by identifying core competencies and having other robust discussions about what's needed in the training programs to really also think about in the future what is needed for the professionals already in the field and what continuing education currently exists and where are the gaps. So the kind of medium-term goal would be to try to make new continuing education or to point out where there already exists fantastic continuing education resources that we could really direct folks to so that when they're out in the field, they can learn about these issues as well and incorporate them into their daily practice. In the long term, we'd love to see licensing exams and other types of exams incorporate nutrition-related questions, but kind of viewing that as really a big hurdle. And so kind of going from first this year, working at core competencies, slowly adopting them with medical schools, oral health schools, all different health professionals, medium term, and then long-term goals in the future.
And finally, Charlotte.
For the research task force, our long-term goal or vision is to really support and accelerate research that expands or demonstrates how nutrition supports, services, and interventions can manage chronic disease and prevent chronic disease and health-related disease from happening, and overall just supporting the research base to support implementation of interventions.
Great. And then I know some of you have already started to touch on this as well, but I wanted to sort of step back and think in the real short term what each of your task forces sees as its important first step. What are the steps that you're trying to really take between, say, now and the 8th annual Food is Medicine Symposium next year? What are you hoping to accomplish? And let's start with Charlotte to mix things up a little bit. Yeah.
So we at the Research Task Force, we have 4 main goals, or kind of our short-term goals for the next year. So first has been the Food is Medicine pilot program, which we've been working on over the past few months, is kind of designing from a research standpoint what these interventions would actually look like. And given the bill that was just discussed earlier that was introduced this week, that was based on some of the model language and model interventions that we built out. And so moving forward, and as some of you may know, kind of the way the legislative process works and how it'll continue to transform, we're really working on kind of building out that pilot and building out the interventions and what that would look like. Our second project that we're working on, or shorter term goal, is to build this Food is Medicine National Research Advisory Group. And we're still trying to figure out what that would look like, whether it would be an advisory board or more just a list of names that we would reach out to who are experts in specifically the food is medicine realm. So there's a few boards and advisory boards in nutrition that are out there, for example, over at Siren, and so possibly pulling from them or getting a more specific board that would be able to inform our actual research efforts, and we could give them kind of research proposals or what interventions would look like or models, and they could kind of give us their specific feedback and their expertise on that. A third project that we're working on is to develop a Massachusetts Food is Medicine state plan case study. So essentially just summarizing everything that's been going on from the beginning to implementate, or through the launch in June, and then these task force and coalitions that have come out of the state plan, kind of summarizing what that looked like, what was the process going into that CHOPE and community service engaged in, and hopefully serving as a case study for other states to be able to replicate this work and kind of leverage the current environment and shift towards value-based care across the U.S. And then fourth, this is the last one, is to develop a Food is Medicine research incubator, understanding that one of the major barriers to research is getting funding. Mm-hmm. And so our goal is to be able to have a research fund internally that could support our work, but also we could put out calls for proposals or requests for proposals for other institutions and organizations in Massachusetts to contribute to the research space.
Fantastic. And Kathryn, I know you touched a lot already on the core competency work. Do you have anything you'd like to add about your work over the next year?
Yeah, so just to add to that, with the training curriculums, we're really taking this year to try to figure out what are the key categories of core competencies that we might want to suggest other training programs incorporate into their education. What we did so far is we took a look across the nation and other nations at what core competencies might already exist in the realm of nutrition, and then had some great discussions initially on that, pulling from those ideas and then discussing amongst ourselves what would fit Massachusetts, what would fit our training schools the best, and what are the priority areas. So right now we're in the process of having 7 different categories for core competencies having been developed, and figuring out how do we whittle down, and we're surveying our task force members to figure out what is the most important of these 7 categories and how many of them to recommend, because we certainly don't want to overwhelm training programs. So we're kind of figuring out what's the sweet spot, and so we'll go more on that in depth this year and hope to have those by the end of the year so we can recommend them to other training programs.
Absolutely. And Jean?
So first, what we have really, I think, succeeded at so far is in having diverse representation on our task force. Mm-hmm. We are really fortunate to have folks here today, but in the task force actively engaged from across the entire state. And throughout the entire continuum of services. So that's been really exciting, and we hope that that continues to grow. But we are also working on our intervention definitions, as I mentioned, throughout the continuum. We have definitions. We're now putting together standards so that we can put some more flesh around, for example, what nutrition standards should apply, what interventions are appropriate for specific vulnerable populations, et cetera. So we're working on that. And then we're also on track to share, by the time we come back together next year, an inventory of programs throughout the state that are categorized by intervention type, and that will then have the standards associated that we think will be an excellent tool for physicians to have, because we're always asked for that. So.
Absolutely, and that really gets to that issue that we've heard in the listening sessions about just a lack of knowledge of what exists in the community, so addressing that critical need. So I think I'm going to turn it over to Sarah, who I've seen walking around getting some questions.
Very good ones. Okay, so regarding the goal that we've heard discussed here to have food as medicine interventions treated like prescriptions, do we think on this panel that healthcare should only cover interventions if they save money? Because that doesn't seem to be the standard that prescription drugs are held to. So why should these interventions be held to that standard?
Who wants to take that one? Kathryn, you look like you're thinking deep thoughts here.
I'm thinking deep thoughts, absolutely. Well, I think cost effectiveness is just important no matter how you cut the cake, because it's a lever to getting more physicians and allied professionals to be able to start screening and intervening. You know, our medical system and allied health systems, you have to think about where the money is coming from, and insurance systems do pay, and you have to think about what's reimbursable. And part of the problem is sometimes, or a lot of the times, many of the times that we screen for certain things or even have nutrition conversations aren't readily reimbursable. So if you're going to make the argument to, you know, physicians, dentists, et cetera, you should make time in your busy day. I mean, think about a physician visit that's only 15 minutes. It's important to screen and intervene. One of the feedback is, you know, is it reimbursable? Because we really do have to also think about overhead. So cost, whether we like it or not, is part of the conversation. You know, in a perfect world, would I like it to be involved? Not at all. But I think it's an important lever that if we don't address, we wouldn't do our due diligence. So I think we have to think about it.
Mm-hmm. Anything to add to that? I was going to maybe point to the research task
Yes.
force. How is this question kind of playing out in your work?
Well, I think it's really just the understanding that it's essential to focus on prevention if you want to reduce costs. And that's what we're trying to do here, and that's what, you know, we're trying to do with ACOs and flex services, and this understanding that instead of treating the costs with whoever said the pharmaceuticals that are super expensive, you know, focus on things like housing, think about things like employment and food. That's really where you're going to drive down costs before these diseases even come up, and we see that countless times in our research across the board.
I just hope, though, that it doesn't end there, and that we can also start, once we do crack this, and I think that we definitely will. We've seen the research is very encouraging. I hope that then we can start looking at factors that are more pertinent to quality of life. And I think that that also is relevant to payers and providers. And certainly we know that there is this issue of physician burnout. And I think that physicians want to feel that they have done something to really change and improve the quality of their patients' lives.
Well taken.
And I also just quickly want to emphasize that it's not just focusing on the costs and the interventions at the healthcare level, it's really focusing on it at the policy level as well. So just cue that up.
And so we've heard a lot about the flexible services program here tonight, and we're all very excited about it. But for this panel, you know, do you believe that this ACO structure and the things that are being done through it are really the appropriate vehicle to build a community-based infrastructure to provide access to these services? How are you seeing this play out on the ground? Can you speak a little bit to that?
Sure, I quite understand.
So I might jump in here just in case it helps to get things going. So I think the point that this question is getting at is this question about where to focus resources. Is it at the community level or is it at the individual patient level? A lot of what the Flexible Services Program is doing is sort of focusing at the individual patient level, thinking about who are the most vulnerable patients and how do we address their particular needs, which I think is great, and we've seen in the research some great outcomes from that. But I think we've definitely heard in the community across Massachusetts that there is a concurrent need to think about the community and to think about broader interventions. And so I could highlight that I think while flexible services maybe isn't getting there, I think that there are other programs that are being established that are looking to fill that gap. So for example, there's a new program called Mass Up that's going to be coming online that is much more community focused. There's an RFI actually out on that from the Health Policy Commission that's looking to shape that program to both provide funding and also to provide sort of an interagency collaborative effort to think about how, statewide, across agencies, across communities, how are we really working together to address these issues. So I would say maybe if Flex Services isn't getting there, there are people thinking about it and there are efforts to get at the community.
Yeah. And I would add to that too, is the question, I think I took from that question, are ACOs kind of a good or a bad thing and Flex Services? I think time will tell. But I think the really important part of that for me is that I've seen tremendous momentum, I think, gather as soon as we started talking about ACOs. And from my point of view, I've been in both working in hospitals, but also working in community-based organizations. And I think one really good thing that has come about in the past few years is that it used to be that these two different groups really never talked to each other an awful lot. And with the involvement of ACOs and the highlight of prevention, now hospitals are having conversations with food banks and all these different organizations and vice versa, versus before the worlds were very split. So, and I think we've all, sometimes there's also a barrier of not understanding one another. The hospital medical world may not understand CBOs, community-based organizations, and their language. CBOs at the same time may not understand the hospitals in the same vein. So by having them start to work together more profoundly with Flex Services, ACOs, and other programs that are out there, I think we're really starting to break down barriers and for an understanding to be achieved on both sides so that we could really go forward and create some really amazing interdisciplinary work. So that's my goal, my hope.
Absolutely. I think we have time for one more quick question.
So I've gotten a couple of questions that are sort of along the same vein, which is that, a lot of what we're talking about here today seems to be downstream intervention. So how do we make the patients a real partner in this, intervene sooner, get information that needs to be gotten out to people about diet earlier? How will this effort inform that?
I think this really goes back to driving home the piece about policy, and if you're going to focus upstream, you really have to take a systems policy approach to it. So if we're talking about food, we need to talk about federal nutrition programs and expanding access to that as just one potential policy lever that can be used instead of, again, focusing more on these more mid and downstream interventions. And then beyond the food realm, we have to look at things like wage gaps and employment and housing, and it's just such a huge breadth of things that need to be addressed at the upstream level if we're really going to address the downstream intervention and costs at the healthcare level.
But I also agree with Kathryn that this does have to be an interdisciplinary approach. The healthcare system is not going to bear the entire burden that far upstream. I think that's when you start to have to bring in social services organizations and identify where are their gaps and how do we fill the gaps through sustainable funding that does not necessarily depend on healthcare dollars.
Oh, definitely.
Yeah.
I'm really aligning agencies in the same vision instead of all working in silos in the way it has been.
Absolutely. Anything else at that point? No. Well, I think now we're going to turn to our keynote. Thank you all so much.
Good evening, everybody. I'm David Waters. I'm the head of community servings. And as Robert said at the very beginning, we're so delighted to have you here and really get into some of the micro details of how do you build this kind of policy, and which I just think is incredibly exciting. I'm here to introduce Lauren Taylor as our keynote speaker at this year's symposium. Lauren is a fifth-year doctoral candidate in health policy and management at Harvard Business School. Fascinating background. Her primary research interests are in inter-organizational relationships and institutional integrity. Before entering the PhD program, she earned a master's in public health at Yale and a master's of divinity with training as a chaplain at Harvard's Divinity School. In 2013, she co-authored a book titled The American Healthcare Paradox. She has since written broadly on the integration of health and social services and financing of social determinants of health. Lauren's background is particularly relevant at this moment, given that healthcare policy and financing are beginning to catch up with the growing body of evidence demonstrating the impact of integrating social determinants into healthcare payment and delivery models. As we know from this evening's speakers, the Mass Health Flexible Services Program offers a first-in-the-nation opportunity to experiment with the integration of nutrition into healthcare models for individuals coping with complex medical and social needs. Community Servings research, published this spring in JAMA Internal Medicine, demonstrated a 16% net savings in total medical expenditures for individuals with complex illnesses who received our meals versus a matched control group. This is our third published study in 4 years, with the 3 studies demonstrating reductions in spending on big-ticket healthcare services, including hospitalizations, emergency room visits, admissions to skilled nursing facilities, and ambulance services, all major drivers of healthcare costs. That's in addition, of course, to better health outcomes and quality of life. With the rollout of the Flexible Services Program, there is now an exciting opportunity to realize the savings from medically tailored home-delivered meals through the Massachusetts Medicaid program. For community servings, this could be transformational, as we have contractual commitments with 6 of the Mass Health ACOs, with which we expect to double the number of meals we serve and allow us to expand our services to meet the needs of critically and chronically ill individuals throughout the entire state of Massachusetts, going from about 25 communities to all 300 communities. As Lauren will share on a macro level, with this opportunity, there are also significant challenges. For example, in our culture at Community Servings, we embrace employing individuals referred to us through the criminal justice system. And when engaging with a potential healthcare contract, we were told that we could not work with any employees, they could not work with any of our employees who had a criminal record. We pushed back on that and got them to change their policies because we were not willing to contract with an ACO that would have us compromise our mission, values, or culture. But it gets to that tension between healthcare and community-based organizations. 2 very important parts of the community, but with sometimes competing interests. We have also had to invest significantly in our systems to ensure compliance with patient data security, a streamlined process for referrals, billing, and contract negotiations. And even with these investments, there remains significant work ahead in making sure that the processes are aligned throughout multiple ACO systems we might partner with. Despite these challenges, we believe that the collaborative work between ACOs, CBOs, payers, providers, and policy leaders throughout the state will lead to a transformation in our healthcare and social services systems within Massachusetts and will serve as a model for the entire country. With this perspective of perhaps cautious optimism, it's my pleasure to introduce Lauren Taylor.
I just have to start by saying I've been around a lot of Manels in my life. It was really nice to see a Wanel. I am going to talk about a dissertation paper that I have been working on for the past 3 years, and it's titled Growing Towards the Light, Community-Based Organizations' Response to Healthcare's Embrace of Social Determinants of Health. So just to flag this at the start, Food organizations are part of the kinds of organizations that I've been studying. It's not all of them. It's a broader look at community-based organizations that do social determinants, but that could be housing, that could be food, it could be domestic violence. And so I'll try and double click on some of the food insights, but I also would love in the question and answer period if you guys would help me make some sense of it, because that's what I am always doing, trying to kind of improve the work, refine the work. And I think you guys are closer to it, frankly, than I am. So here, we've heard about this already, but I just wanted to flag, in case there was not such a nice policy primer here, how many health policies are really trying to incentivize healthcare organizations to pay greater attention to social determinants of health. So of course it's here in Massachusetts with the mass Medicaid redesign, but it's fairly nationwide. I think what we're finding in the academic literature is that to date there's been a lot of focus on how is healthcare metabolizing this shift in focus? How are they adapting their workforces? How are they adapting the way that they measure their outcomes to think about social determinants of health as part of their workflows? But there's not really been a lot written on, okay, well, there's a whole other part of this equation, which is the actual community-based organizations or the social service organizations. I'll use those terms almost interchangeably. The policies, I would say, frankly, just rely on this incredibly robust and efficient social service delivery network to be coming into fruition and taking care of all of these referrals that we're kind of drumming up in the healthcare system. And so the goal of this work was to really understand, okay, let's think about the community-based organizations here in Massachusetts. What do they know about mass Medicaid redesign? How are they perceiving it? Frankly, I had competing hypotheses on that. On one hand, I thought they could be feeling like, great, finally someone is taking my work seriously. I'm really jazzed to see these policies coming into fruition. But I thought they could also be perceiving this as a huge competitive threat. Like, if you know about healthcare, you know it just wants to grow and grow and grow. It is a feed the beast kind of organization. And so my thought watching it was, ooh, if I'm a food organization, I might be nervous, frankly, when I hear BMC has started a food pharmacy on site. And when I think about the kind of contracts that healthcare organizations already have in place with the likes of Aramark and other food delivery services, maybe they would just try and take that work on themselves. So those were the competing hypotheses. The research question I started with, and we started with, this is a collaborative work with Elena Byhoff, who's a physician at Tufts, was just that. How are community-based organizations perceiving and responding to this fairly recent entry of healthcare organizations into social determinants of health programming? This was a qualitative study, so we did 46 interviews with community-based organizations around the state. And as I said, this is collaborative, so Elena Byhoff, a physician, was my partner in crime here, and we were funded by Blue Cross Blue Shield Foundation of Massachusetts. The method, just briefly, as I said, is 46 key informant interviews. We developed an interview guide. I'll show you who we talked to in just a moment, and I don't think I need to go through this for this audience, but I'm happy to talk more about it. We were collecting data, this is important, between October 2017 and March 2018. So if any of this feels like, oh yeah, I could imagine that happening, but it feels dated, that's a totally fine critique and limitation of the study. Things do continue to move very, very fast, and part of what I may do in the future is go back for a kind of double up round. So just to be clear about who we talked to, we considered community-based organizations to be social service delivery organizations, and then to the extent that there were kind of professional organizations that represented a whole group of community organizations, we talked to some people there too. So think about the Boys and Girls Club of Massachusetts. We did not talk to them, but to the extent that there was some kind of professional organization that had people who did lobbying and advocacy for all the Boys and Girls Clubs, that would be kind of that top rectangle there. We were not talking to healthcare organizations, and we were not talking to organizations that did purely advocacy, or they were kind of bridge organizations. So people in this room may be familiar with a group like Health Leads. Health Leads we considered to be a bridge organization, and they were not in our sample. Here's who was in our sample. So I put nutrition at the top just so you can see it. 6 of the 46 were pure nutrition organizations. So that means they were either kind of Meals on Wheels, medically tailored meals, food pantries, food banks, et cetera. But then, of course, there's nutrition services littered throughout here, especially in that multi-service centers or organizations. There are many social service organizations, frankly, that just defy categorization. You go in and you ask what they do, and they have grown over time to be responsive to a whole set of social needs. Many of those do things like SNAP enrollment, and so they would have a nutrition component as well. So here's the finding. Essentially, we found this kind of puzzling thing where when we talked to community-based organizations and we said, how are you thinking about the Medicaid rollout? How are you thinking about the development of these Medicaid ACOs, flex services? they said two things that were kind of contrasting. On one hand, CBOs said, we really value our distinctiveness, and we know that organizations like us in the past have been medicalized, and we do not want to be medicalized. And so the kinds of organizations they would point to were things like community-based mental health services, which they thought had just been like fully swept up into the medical industrial complex, aid service organizations, some hospice palliative care organizations that once upon a time were 501c3s independently and are now largely owned by hospital networks or groups. So they said that on one hand. And yet when we asked them, okay, so tell me about like what's moving and shaking in your organization, they described all these ways in which what I would interpret it as they're adopting new ways of working from healthcare. And so this is kind of I wrote a book called The American Healthcare Paradox, and sometimes I think we could have titled this like the CBO paradox. How is it you're telling me so strongly you really value your distinctiveness, don't want to be medicalized, and yet you're also telling me, as I'll show you in just a minute, ooh, but I'm actually hiring a physician, and we're going to try and bill Medicaid. Oh, and I'm actually going to start tracking the readmissions and my impact on readmissions. I think, so this was the second question, kind of like what can explain this? And I think this is the rationale. So, and I'll tell you more about each of these in just a moment, but I think the way we can make sense of these is to understand that many community-based organizations experience like borderline profound resource scarcity. So one of our key informants said to us, Lauren, you've got to understand this is a sector that operates in a mindset of poverty, meaning our managerial mindset is a mindset of poverty. And we perceive healthcare organizations as resource rich. You will love some of these quotes. People said things like, oh, you know healthcare, they've got a lot of money just sloshing around. And so this is like a key insight of institutional theory. It's not necessarily unique to this context, but when a group feels like, ooh, we need resources, and that group over there, they have resources, one way to do that is to kind of try and mimic that group that has resources and or appear as legitimate in the eyes of the group that has resources, because then maybe they will give you contracts and things like that. And so if you fill in that kind of middle group, it starts to make sense. Okay, they really value their distinctiveness. We've got this like initially a knowing doing gap, but they feel poor and they think healthcare's rich, so they think maybe we can hook our kind of trailer to that automobile. And in that way, we may be able to rationalize the value of the distinctiveness, but also the adoption of the new ways of working. I'm just going to show you some of these things very quick because I want to leave some time, but some of the best quotes. These are just slides that are set up with one of the titles at the top. Codes, don't worry about it. It's just kind of the piece of text that we use in qualitative analysis to say, this is what we think we're hearing in this part of the transcript. But these are the kinds of things people said to Elena and I. And let's look at the second one here. When they're talking about their distinctiveness, CBOs would say, a hospital is where you go when you get sick. A community is what builds the health of everybody, so you only need to go to the hospital when you are sick or injured. Trying to like draw this line about this is what they do and what we do is something different. And then there were all these concerns about medicalization. People said it explicitly. I really think we shouldn't medicalize this broadly because if we do, we'll view it through a medical lens and not a human lens. This is a fabulous quote, and it's long, but I'm going to read it because I really think it speaks to something so deep. The CBO person said, I'm concerned that healthcare will want to make this into tight compartments that make sense, and the social spectrum does not work that way. But they'll want to define it, encapsulate it, put borders and boundaries around it, and it will no longer be a social determinant. It will be a new service line. That would be, I think, a tremendous detriment. So that's the kind of knowing. They know they don't want to go that much closer to healthcare, but this is the doing. They're adopting the new ways of working. What does that sound like? It sounds like, I think since the ACA was passed, it's really created these opportunities to reach out in a meaningful way and think about partnerships. So I think probably over the last 4 or 5 years, we've actually added someone from the healthcare sector to our board because we can see this is a really key link, these two areas. Similarly, I believe this was a food organization, said, our registered dietitian can actually bill for services. Just to be able to play credibly in the space, we have to, meaning we have to have these kinds of people on staff. They're also talking about and measuring their work in terms of health, and these I won't read to you, but lots of talk about health and cost outcomes, even trying to track the impact of a social service organization on things like hospitalizations, emergency visits, ambulance calls. These are incredibly specific healthcare metrics, and things that I would just caution you all, healthcare has had an incredibly difficult time moving as like the direct intervention on ambulance calls, emergency departments, et cetera. But here are community-based organizations recognizing that the opportunity is there. If you can make a claim and if you can provide evidence that you can move these things, you suddenly have real standing to potentially get healthcare contracts, Medicaid billing numbers, et cetera. Finally, this is, I believe, a food organization as well, who said, look, we're actually changing one of our key performance metrics. Once upon a time, we worried about pounds of food delivered to the community. Now we're really talking in terms of healthy meals. The resource scarcity is more or less self-explanatory. I mentioned at the beginning, CBOs talking about a mindset of poverty. But constantly, every CBO across all those sectors, food, housing, domestic violence, childhood education, everyone says we're really, really thin. Government contracts, which are the main lifeblood of the organization, do not cover the cost of operation. And so everyone is always looking for additional sources of funding. Here are the fun ones. So perceptions of healthcare as resource rich. I'll just go over the bold again, but people were referencing hospitals as having pretty significant resources at hand. Money just sloshing around so they can invest, unlike most human service organizations. And then it wasn't just, when I say resources, it's not just the cash on hand, it's also some of the managerial and other resources. So people saying things like they have a phenomenally sophisticated administrative base, which you could tell, you know, the subtext there is in some part, and we feel our administrative base does not match theirs. So again, adding fuel to this idea that how do we look legit? How do we look like we're ready to take a contract? You know, you hire their kind into your organization. Oh, this is the most explicit one. We see healthcare organizations as having a lot of money, and we want those dollars. Sometimes I'm like, it doesn't take a PhD to do this work. And then here are just like some more quotes on the deliberate effort to engage. So there were people saying there's been a more deliberate effort to market, to try and develop relationships for referrals. Things like hospital name is such a big player that it enhances our name to have a relationship with that hospital. Things that were like, I think that partnering with healthcare legitimizes what can sometimes be seen as, oh, that's just basic needs. But note the language here. But it's really crucial to really big issues like healthcare. As if basic issues are not big, healthcare is big. So finally, this is what I've tried to give you a story of. I think it applies to the food industry. It also applies beyond. And sorry, when I say industry, I mean community-based organizations, not like Monsanto. CBOs value their distinctiveness and are aware of the risks of medicalization, but they experience a resource scarcity and they perceive healthcare as resource rich. And so CBOs are deliberately kind of coming up with strategies to try and increase their legitimacy in order to secure resources, which help us explain why it is, even though they value their distinctiveness, they're also adopting healthcare's ways of working. What's to be lost? You know, it's up to each individual observer at this point to figure out whether or not we think this is a welfare gain or a welfare loss. In certain rooms I'm in, especially with housing organizations, they hear this and they say, ooh, we do not like the sound of this at all. This sounds very scary, very much like our work is going to be medicalized in a way that feels like corrosive or corruptive. Other areas that I'm in feel like, great, you know, this is what we've been waiting for, and I kind of sense that this room is more on the latter than the former. But there is still the loss for some intrinsic values for community-based organizations. David was describing before this issue around criminal justice employment. Other kinds of community-based organizations often rely heavily on volunteer labor. That's another kind of CBO attribute that could get driven out as healthcare comes to the fore and says, yeah, we want to really create a contract or we want to purchase a good for you. These other things like cultural attentiveness, attention to long-run outcomes, I always say, I think the last thing healthcare is going to want to buy from a social service organization is a community organizer, but the community organizer is often like the most key member of many community-based organization staff. And so one physician put it to me as, you know, what we're looking at is think way, way down the road. This is like worst case scenario, but if you really took all the CBOs and dragged them downstream, you would essentially have a loss of primary prevention capacity at the system level. So I said already it's difficult to know at this stage whether the CBO changes are ultimately going to be positive or negative. I titled this thing Growing to the Light, Towards the Light, because I think I can give you guys an account of the kinds of changes that are happening and potentially an explanation for why those changes are happening. But I don't think at this point we can say necessarily whether it's good or bad. And I would just double click on that word medicalization. There's many rooms, as I was saying, where medicalization is a very dirty word. but I think that one person's medicalization is another person's professionalization. So sometimes I'll go into a group and I'll say, community-based organizations like Community Servings, they're getting into these randomized control trials and it's being phenomenally successful in helping them make a case to healthcare. Some people will hear that and say, we should not be doing RCTs on all of our social service interventions. And they just think categorically that's not the route that we want social service delivery to be going. And other people say, no, that's exactly what we should be doing. We need to be raising the bar around the kinds of evidence that we accept for social service interventions. With that, I think I am going to pause, finally, after running through those slides very quickly. I think we've got 5 minutes, and I'm happy to take some questions.
So just a reminder, I'm going to come through and you can wave your cards at me. If you need a card, I can give you a card. I'll start you off, Lauren, with just, so as you know, many of us in the room are members of the Food is Medicine Massachusetts Coalition. We're going to follow Flex Services very closely. What do you think that members of this coalition should really be paying attention to as this rolls out, given your work in this space?
Yeah, so I think one thing is to just manage our expectations around what the outcomes for Flex Services are going to be. Flex Services is like a first step for Medicaid putting a baby toe into social service delivery. And so Medicaid staffers did the right thing in terms of they were risk averse. And they said, we only want to pay for these kind of, in the housing area, for instance, it's housing search, it's housing navigation, but we're not paying for the creation of new housing stock. And we've got an 8,000 person waiting list in Boston for affordable housing. So to the extent that you get one of these like magical Flex services, you're getting housing searched or housing navigated, frankly, to the end of an 8,000 person waiting list. And so to the extent that we think Flex services are going to show like incredible health improvements and incredible healthcare cost utilizations, I just think we need to be careful in looking at the fine print and saying, what are we actually using these dollars for? Because it's fairly narrowly constrained. I think in the food space, there's reason to be more optimistic, but I think even if you talk, there's only so much capacity Community Servings has. And so I think we still just need to both manage our own expectations and be thinking already about how we measure the influence of the Flex Services programs, particularly around the process measures, so that we can then make a case in 2-3 years' time, 5 years' time to Mass Health that look, even though you didn't see a 50% drop in utilization among Medicaid enrollees who got Flex services, there's reason to continue to want to experiment, invest in this area.
Then given sort of what you said about, well, we don't really know whether we're going in the right direction or the wrong direction, and you said you might go back and do another look at this, what would be indicators to you that we're going in the right direction or the wrong direction?
Yeah, so the deep existential question at the heart of this program, program of research or paper, is how do you integrate without totally homogenizing, right? So how do you let healthcare and social services talk to each other? You build bridges for them to share patient information, work collaboratively, without letting healthcare fully kind of trump social services and exert their power to say, you've got to do things our way. Because really that defeats the purpose, because the whole central insight of social determinants of health is there are some things beyond the scope of the healthcare service provider that are really important for health. And so if we let healthcare kind of dominate the social services, which I will say is not totally unlikely given the relative size of the two organizations, you potentially just fail to capture the synergy that initially motivated you to even think that healthcare and social service integration or partnerships was going to be a good idea in the first place. So what would I be looking for? Frankly, one of the things that I'm paying very close attention to is RCBOs getting themselves into pay-for-performance contracts in this initial 1 to 3 year window. I think that would be a really dangerous thing. Healthcare doesn't know how to manage their own pay-for-performance contracts. I think it would be much too soon to be putting homeless shelters, domestic violence organizations, utility assistance organizations into pay-for-performance. I think, frankly, when I hear CBOs telling me we really think we can change some of these very difficult readmissions, I start to get a little bit if you're community servings, maybe. Community servings is in some ways like a unicorn in this CBO space. I think when we hear other community-based organizations saying, yeah, it's going to be hospitalizations, I start to say, I don't know. maybe one final insight on this, just to give you guys a sense again of the ways in which I've learned about the differences between CBOs and healthcare. When I go to healthcare and I say, how do you know what good quality care looks like? They say to me, standardization, meaning every patient who walks through the door with the same clinical presentation, I give them the exact same workup. That's what good quality care is. And that's not just good quality, but that's like an ethical obligation on the part of the medical establishment. When I go to many community-based organizations, and I thought Jean's comment before was really interesting about standardization, many community-based organizations, when I say, how do you know what good care is, they say something to the effect of, everyone who comes through, we tailor our approach to fit the unique needs of that family and individual. And so I just continually hear this again and again. Good management in healthcare, standardization, routinization. Good management in social service organizations is the ability to tailor and meet unique needs. And certainly there's a middle ground, and frankly, both organizations clearly understand the value of both, but trying to bridge that chasm and allow those two organizations and worlds to see the value in one another's ways of working, I think is part of the work ahead.
And then I have a question about, so how CBOs generally being sort of the little guys, healthcare being the big guys, as they're having these conversations, did you see any sort of strategies that they were adopting to be successful in kind of preserving their core missions and values? Or is it too early to tell?
I can give one tip. I mean, the bigger you are on the CBO side, the more evidence you have under your belt, the kind of stronger stance you have at the negotiating table. I would say one of the real challenges for many CBOs is knowing their own unit cost. I mean, that's a big challenge for healthcare too, but we're living through a moment at which social service organizations are being approached and saying, tell me what it costs you to house someone for one night, and trying to figure out how to distribute fixed costs is not easy. But I would say one tidbit that I have learned that seems to make these organizations work better together is having someone on either end of the kind of phone with the same training. So if you get to have a Dr. B working at a social service organization, she's an MD, and that means that the Greater Boston Food Bank can have a discussion with some kind of healthcare organization, and it's a doc-to-doc conversation that really helps facilitate the whole interorganizational relationship. It doesn't have to be a doc. When you have medical legal partnerships, you get lawyers talking to lawyers. That works well. In other cases, I've heard social workers talking to social workers. But anytime you've got really different organizations, think about them as different shapes. This one's a rhombus, this one's an oval. Anytime you can create some connective tissue where they have the same little shape, just if it's individuals talking to one another, that seems to be really facilitative, because those people on the phone have some kind of shared professional language and reference points through which they can funnel all the other diversity of the two organizations.
And we have a question that relates to the American healthcare paradox. So in that book, you described the disproportionately large social spending in the US on healthcare relative to other, or disproportionately small, right, social spending in the US on healthcare? Oh, large spending on healthcare relative to other rich countries. So would the growth and professionalization of CBOs to facilitate integration with healthcare be part of what could help that paradox? Sort of.
It's a really good question. One of the reasons that we've not gone back and replicated that study, which showed large healthcare spending and relatively smaller social service spending in the US, is because now you have things like flex services. So now we're in an SDOH world where a lot of money that is ostensibly for social service organizations would now show up as healthcare services. So I think the challenge now is, as we see healthcare costs continue to grow, how do we disentangle what proportion of that is us as a society trying to funnel social service dollars through a healthcare system, and what part of it is just like the traditional, the prices are going, we've got waste and administrative burden.
Thank you so much. David Waters is going to come back up to close us out.
Lauren, I think you bugged my office. I think we've said almost every quote that you read in your study. I just want to wrap this up by saying, as a social entrepreneur myself, I think there's an incredibly exciting and interesting story to be told here, and I think Lauren's piece is sort of the headline, but I feel like at Community Savings we live and breathe this tension between healthcare and human services, between professionalism and community-based services, between the basic human right that people ought to be fed and the business argument of cost savings in healthcare and improved health outcomes. I think how we figure those out over the next 5 years will be as interesting as the 5 years we've traveled so far. And I hope you will all be there with us, because I think there's a fabulous book being written here somewhere amongst all this. I want to thank those of you who serve on the FIMA planning group. It's incredibly exciting to hear your work. I want to really give a shout out to Lauren, who I just saw sneak out. And I want to thank all of you for coming. Because at its heart, the work that we do is community work. And you can't, no matter how professional we get, if we lose the community, in our case, the community in community servings, but really the community in all of our organizations, we will not be richer for having healthcare resources. We will ultimately be poorer. So I think we have to hold on to that, and that's the community we have here in the room. And in that spirit, we're having a reception outside. I hope you'll join us for a little more community. And if you happen to be from the Cape, from Cape Cod, we'd love you to come down here for a quick photo after, because we want to send it to Senator Sears to thank him for the new bill that he's just placed, and to show him the kind of support we have amongst all of us. So thank you again. Join us back here for the 8th Symposium next year.